Good morning and welcome to the June 2021 AMA section meetings. My name is Russ Kreidel and I serve as chair of the AMA Board of Trustees. It's my honor to be with you today to guide you through our plenary session. Now, we all know the last 18 months have tested us in ways that few of us could ever have imagined. So I want to extend my great thanks to all of you on behalf of the AMA Board for all you've done during this incredibly difficult time for your patients, your communities, your families, and in your help to the AMA to lead as physicians' powerful ally in patient care. Thank you also for your commitment to keeping our AMA's policymaking efforts strong by participating in these virtual section meetings. And I'd also like to take this opportunity to thank our president, our board, and management for being so nimble to channel the AMA's efforts and everything into solving the challenges that the pandemic presented to us. Much has changed over the last year, which we'll discuss in today's plenary session. We have a dynamic program planned for you today. We hope you enjoy it, and it will focus on challenges in healthcare that were amplified by the pandemic and how we can address those issues going forward. So let's get started. It's my great pleasure to introduce our AMA president, Dr. Susan Bailey, hailing from Fort Worth, Texas, for some remarks. And she'll reflect on the issues we've tackled and on our accomplishments to date. Dr. Bailey.
Thank you so much, Russ. Good morning, and thank you for the opportunity to join the sections today. I want to start with a special thank you to the members of our 12 sections and groups. Because we have people here today who might not be very familiar with our sections, let me name all of them so everyone can appreciate the extent to which our sections touch on every aspect of your medical career and practice. The medical student section, resident and fellow section, young physicians section, women physicians section, minority affairs section, Advisory Committee on LGBTQ issues, International Medical Graduate section, Academic Physicians section, Organized Medical Staff section, Integrated Physician Practice section, Senior Physicians section, and our new Private Practice Physicians section. As Dr. Kreidel noted, in the face of a daunting year, you all have stayed active in supporting the AMA. I want you to know how much your Board of Trustees truly appreciates your work and dedication to the AMA. Like you, I've marveled at the tireless work and resilience of our physician colleagues in response to this once-in-a-lifetime health emergency. Physicians across the country have worked incredibly hard to turn the tide in this pandemic, working long hours at great personal risk to themselves and their loved ones. They want to know that the AMA has their backs, and we do. Since the beginning of this pandemic, AMA has worked to deliver the PPE, resources, and support physicians have so desperately needed to fight COVID-19. Make no mistake, everyone has experienced hardships in this pandemic. This is true whether you're a physician on the front lines of the COVID response or whether you're a physician in private practice just trying to weather the economic storm of the pandemic. The AMA has been there for all of you, and we will continue to fight on your behalf until we reach the end of this pandemic. The AMA continues to fight aggressive scope of practice expansions around the country as nurse practitioners, physician's assistants, optometrists, and other groups seek to expand their roles. The AMA has worked with more than 20 state medical associations this year on scope of practice legislation. And since 2019, we have helped secure more than 70 legislative victories, stopping scope creep. But we know these battles will continue, which is why the AMA has doubled its contribution to the Scope of Practice Partnership for 2021, which has made a huge difference in gathering the on-the-ground resources necessary to fight these bills. Additionally, the AMA, in collaboration with our Federation partners and other healthcare organizations, recently scored a huge win for physicians by pressing Congress and the Biden administration to relieve some of the financial pressure on physicians by extending suspension of the Medicare sequestration and the 2% payment cut through the end of this year. And the AMA will continue to work with our Federation partners to offset additional payment cuts that hurt physicians at a time when we can least handle it. A recent national survey by the AMA showed the depth of this pandemic's financial strain on physicians and practice sustainability. 8 in 10 physicians said their revenue was lower than at the same time the year before. Telehealth, while a critical lifeline for physician practice in this pandemic, was not enough to fully offset revenue losses. 64% of physicians said they were spending more on PPE, while at the same time having a difficult time acquiring it. The AMA has helped secure billions in funding and financial aid for physician practices since the beginning of this pandemic, but it's clear that all of us in organized medicine need to do more to help practices regain their financial footing. The pandemic has also disrupted medical education, which is why AMA, with assistance from our medical student section and resident and fellow section, created resource guides for medical students and residents to navigate complex issues around COVID-19. Finally, the pandemic has revealed perhaps more than ever glaring disparities in health outcomes for our patients. We know that widespread inequities negatively impact the health of our patients. Job security, education, availability of fresh fruits and vegetables, access to public transportation, and a host of other factors influence a person's or a family's chance for a healthy life. And we know that certain groups and communities are at a distinct disadvantage in navigating our health system, without access to treatments, tests, and specialists readily available to others. These gaps are different elements of the same troubling story: the role of racism and social injustice on healthcare and society. As you saw with the release last month of AMA's plan to embed racial justice and advance health equity, we recognize the need and the opportunity for our AMA to play a role advancing health equity, working alongside these communities and with other stakeholders. This is especially true as we emerge from this pandemic, and we look forward to hearing more on this a little later in our program. With several safe and effective vaccines for COVID-19 now in wide circulation and our country beginning to reopen, the end of this pandemic is in sight. But as we emerge from the pandemic, the world around us will look very different. The pandemic revealed challenges to how we practice medicine, how our patients access care, and how we pay for it. The pandemic also presented unique and ongoing opportunities for our profession to innovate, to test, to reshape care to better and more equitably serve our patients. Even as COVID-19 fades, know that our AMA's work will continue, and we will be out there fighting for you, stronger than ever. Thank you for being here today and for sharing your knowledge, your experience, and your perspectives. The activity in which the sections are about to engage, shaping policy to guide the actions of our AMA, is more critical now than ever. It's only with your continued passionate engagement that our AMA can speak with a unified voice as the physician's powerful ally in patient care. Now, back to you, Russ.
Thank you, Dr. Bailey, for all the work that you do tirelessly for the AMA, especially during this unprecedented time with such articulate speech and passion. I'm now pleased to introduce the next part of our program, Dr. Shantanu Nundy is Chief Medical Officer at Accolade and Senior Advisor to the World Bank. Dr. Nundy is also a primary care physician, internist in a safety net clinic in Washington, D.C., and the author of a new book called Care After COVID: What the Pandemic Revealed is Broken in Healthcare and How to Reinvent It. Now, today he'll be talking with Todd Unger, AMA's Chief Experience Officer, about a new framework that he's developed for healthcare post-pandemic and the central role of the physician in leading the change ahead. Todd, please proceed.
Welcome, Dr. Nundy, and thank you for being here today. I'm excited to learn more about your framework and share that with our audience today. Before we get into the details of the framework, why don't you start by talking a little bit about the background? Was this something you were thinking about before COVID?
Yeah, Todd, well, it's such an honor to have a chance to chat with the AMA about some of the things we've been thinking about. And, like a lot of physicians, I think we're always trying to find opportunities to improve care for our patients. And so I think in some ways, you're right. I think the ideas behind the book have been sort of in the back of my mind for some time, but it was really the pandemic. I think for all of us, seeing our country turn sideways, I think got us a lot of us thinking about how we could do more to serve. And for me, it was particularly early on, a lot of the concerns about testing and access to testing that really led me on this journey to put down my thoughts on paper.
Were there any other things in that kind of pre-pandemic area that stick out in your mind as being, already an issue before it got complicated by the pandemic?
Yeah, I mean, one of the areas I think a lot about is chronic disease. I think so many of us physicians are grappling with just incredible numbers of patients with chronic conditions, multiple chronic conditions. It's affecting every specialty and every subspecialty. And so that's an area where for a long time I've thought, this idea of, you come see your doctor for 10 minutes every 3 months, that's just not enough for what patients need to really change their day-to-day behavior. And so that's one area in particular that I've been quite passionate about for years now.
So then the pandemic hits. Can you talk a little bit about how this accelerated the changes that you were already starting to think about?
Yeah, absolutely. I mean, I think for a lot of us, I think, I still get a chance to practice every week as a primary care doctor on the safety net. I think it was really astounding to see the kinds of changes that we put in place, right? So a clinic like mine, I'd never done a virtual visit, never done a telehealth visit, went from 0 to 80% in a 2-week time span. It's something that I think most of us would have thought was impossible. We launched a drive-through testing site. For decades, we've been testing people for, the common cold and influenza in our offices, which may not be the safest thing for us health workers, may not be the safest thing for patients. Suddenly we had a white tent outside our clinic and a nurse with a megaphone directing patients to come there to get tested. Even the way we use data, early on when we got the vaccine, it wasn't available for everybody. We had to follow strict protocols, as you know, for who it was eligible for. It was really the first time that at scale, we were using data from our electronic record to scan it for who were the people that were eligible, and then actually proactively calling them and saying, hey, you're now eligible for the vaccine. You're now eligible for the vaccine. And so those sort of innovations, I think, were essential during the pandemic, but I think there's a real opportunity to use them forward around chronic care and prevention as well.
So let's talk in more detail about your model. As I think about it, there are 3 big Ds that outline your framework. Can you just talk very briefly about each of them, and then we're going to go into more detail about what they mean?
Sure, absolutely. So the first is this idea that care should be distributed, right? Care needs to happen where health happens, which starts in the home, in our communities. And so that means virtual, that means home-based, that means community-based. The second is digitally enabled. I think the real role for technology in healthcare is to increase relationships in healthcare, which are central, and particularly trust. And then third is decentralized, that we need to put way more resources in the hands of frontline teams as well as patients to enable them to make better care decisions for themselves.
And those 3 Ds they're not really independent. They really kind of go together when you think about, say, chronic diseases like hypertension or diabetes. You really kind of need all 3 in place, right? How does that kind of work in your mind?
Yeah, absolutely, Todd. I mean, I think they're very complementary. I think part of the reason for calling them out, right, is because I think that too often the words that we use, I think, sometimes don't do us a service. So, for example, instead of distributed, very often now we're talking about virtual, we're talking about home-based. But I think that misses the bigger picture, right? I mean, if someone maybe has their physician visit virtually, they might need to come in somewhere to get tested. Or if they're very sick, they might need to go to an ER, or they might need to get admitted to the hospital and then come back home. Distributed is I think, a much more inclusive, broader term that says, look, virtual and home is one part of the healthcare experience, but it is just one part. And we need those other parts together in concert, ultimately, to serve our patients. And similarly with digitally enabled or decentralized, I was very purposeful around picking words that I think connotated a very different direction that I think sometimes the healthcare industry would have us think is what's needed, and ultimately much more about, again, that sort of physician-led world that ultimately I think will serve patients best.
So when you think about turning your framework into reality, obviously there are parts of it that are kind of in motion and have been accelerated by the pandemic. But is this kind of a moonshot, or are we talking, near term? Give us some context there.
Yeah, I don't think it's quite a moonshot, but it is a seismic change, right? I think that as frontline clinicians, I think we always have to decide where to invest our time and potentially our resources, right? And I think up until now, we've sometimes taken a very incremental approach for addressing the needs of our patients. So let me give you an example, right? Many primary care practices like mine will often look at their data and say, wow, we need to increase colon cancer screening, right? We know it's recommended for people over age 50, it's underutilized. And so typically the way that we'll solve the problem is we will implement some sort of quality improvement program within our four walls of our clinic, right? So it's electronic record alert, or maybe a list of patients to call. I think distributed is this idea to say, well, that's all important, and how can we reach people closer to home? We know that so many Americans don't even go into the four walls of the clinic. Some of them don't trust going into the four walls of the clinic. And so if you really want to impact colon cancer screening on a population level, what about the idea of actually just mailing directly to people's home, a colon cancer screening fit card, right? Or canvassing them, or going to community places where people are already congregating, people who may not otherwise come to a clinic, right? So that's a pretty material change, because we all have to figure out where to spend our time. And it's trying to say, what we've seen with the vaccine as a good example of that, right, is we could have vaccinated people in clinics, and we are today, but vaccinating people in football stadiums, in their nursing homes, door to door in the community, I think that's been a much more equitable approach. And those are the kinds of things that we need to start doing differently, is my perspective.
So when you think about, these three Ds: distributed, digitally enabled, and decentralized, what do you think are the biggest obstacles to achieving that vision?
The thing I think about the most is really leadership. I mean, clearly we're going to need payment changes. Clearly we're going to need regulatory changes. But I think for doctors on the front line, those feel very far removed from our possibility space, right? But I still think that there's a lot of room, even with the existing payment models and the existing regulatory frameworks, for us to do more, right? I think drive-through testing is a perfect example of that. For 30 years or more, this idea of have people that are, coughing and sneezing, wait in a place we actually call a waiting room to cough and sneeze on each other, only to see us for a few minutes so we can do a test, right? Moving that to a drive-through actually didn't require any payment changes. That actually works extremely well in a fee-for-service world. It works extremely well in a value-based world. It didn't require any regulatory changes, because the same nurses that were doing the swabs within the four walls of the clinic are the same nurses within their scope of practice that can do the swabs outside of a clinic. And yet, I think that's a place where, as physicians, we should feel empowered to say, yeah, why are we putting sick patients where they can, infect each other and ourselves in the same place? And I think, like that, there's now many, many places, many parts of healthcare where I think physician leadership is going to be essential to say, hey, even though we haven't done it this way before, there's a better way to do this. And that's the direction we need to go. And then let's leverage our teams to be able to move in that direction.
Yeah, I'm curious, just, to that very point. I mean, obviously, in the middle of the pandemic, you had to make changes, and
Yes.
you, had to accelerate that. Now proverbial heat is off a little bit, hopefully,
Yes.
for some period of time. Do you think that's going to take away from the acceleration?
Yeah, I mean, I think that's definitely a very legitimate concern, right? I mean, I think this was driven by necessity, right? Just as you said it. But I think there's two things that really give me hope. The first is, I think COVID has been an incredible magnifying, glass on the core challenges of healthcare, right? I think as physicians, even me, I mean, I feel like there's components of care where I'm like, yeah, it's frustrating, the electronic health record and, reimbursement and things, but I think I now have this very visceral lived experience of what it's like to try to get a test for a family member or myself, or a vaccine, or recognizing that fee for service, which none of us love, how one of the challenges that it makes our clinics fragile. Like, we lost revenue, like some of us lost our livelihoods because of this, right? And I think that the data on health inequities, we've been seeing health inequities our entire career, but seeing those charts on the front page of the New York Times with 3 times the death rate in African American, like, I think that has created a real moment now where people are saying this is not acceptable, and not just doctors and not just patients who are the sickest. I think you're seeing policymakers, business leaders, just everyday citizens all coming together and saying, wow, the healthcare system is not working for doctors and not working for patients. So I think that's the first. And the second one is, I mentioned earlier, is those muscles that we've built, right? That better is possible. Like, the speed of change and the scale of change that we've been able to do. And the other point I've been telling people is, we've literally created a generation of doctors and nurses and health professionals who have this experience now, right? We know how to create those kind of delivery changes. We know how to implement public health interventions. If there was another pandemic, we're so much more ready for it. I think we've just given the entire physician community a master's in public health, over the past year. And so while the necessity might go away, those skills, I think, won't readily go away. And so I think there's a real opportunity now.
Well, Dr. Nundy, speaking of leadership, this room is filled with physician and medical student leaders and advocates. Let's talk about what you see as the physician's role in driving and implementing the type of changes that you've outlined in your book.
Yeah, no, it's such an important question. I think that, as physicians, I think we have this incredible privilege of really understanding our patients and really having an understanding of the evidence and outcomes, as well as, I think, we really have the trust and respect of our colleagues. And so, what I've learned in my career is that when you're doing sort of the same thing or something incremental, you may or may not need, a physician at the helm. But when you're actually advocating for a completely different way of doing it, everyone in the room's looking to you to sort of say that this is the right direction to go, right? And so I think the role becomes even more essential when you're talking about these kinds of innovations, right? Because when you're trying something new, right, there's always a risk that it will somehow be worse and patients, would be harmed. And so people are looking at physicians to say, yeah, no, this makes more sense, or there is evidence, toward this, or this is the right thing to do. And it's us using that voice and really pointing in that direction that I think is going to be essential for us to keep pushing in this direction.
Was your hope that your book would inspire these physician student leaders toward this future?
Yeah, absolutely. And I have to say, there's always those days where you're just like, why did I do this? And then you get the email from the medical student who's in his 4th year saying, now I know what I want to do in my life. Or you give the talk and somebody reaches out on LinkedIn. And so that's been some of the most rewarding, moments. And it goes back to the framework. Like, what you'll notice is not in the framework is, okay, do telemedicine for this, or do this remote monitoring, or do that. I think what physicians are looking for, and this generation is looking for, is actually more of a framework that will equip them to make the best decisions for their practices and their communities, right? I think too often the guidance we get is very prescriptive, and it's like, well, that doesn't make sense for my patients. My patients don't have internet access, or my clinic doesn't have that problem, or we're rural and that doesn't work for us. I was very purposeful to pick a framework that gave people that directionality, but also empowered them very deeply to say, looking at your patients, looking at the resources you have in your community, how can you execute toward that direction, but in a way that just makes sense for where you practice and how you practice.
Well, you kind of mentioned this a little bit, and you talked about digitally enabled and your patients. That's a real area of challenge in terms of equity and a consideration, obviously, that you have to kind of take into account working toward a vision like this. You happen to be one of 11 external advisors working with the AMA on its equity and innovation strategy through our Center for Health Equity. Can you talk about this work and why it's so important, and this intersection of health equity and innovation?
Yeah, no, it's been such a privilege for me, and I think what's been true for a long time, but again, only been magnified during the pandemic, is that innovation and equity must be synonymous, right? When we're talking about innovation, the question is for who, right? Who are we doing that innovation in service of, and for what purpose? To improve outcomes. And I think that itself is a reason for why equity and outcomes, equity and innovation must become synonymous. Because when you are trying to improve outcomes and you're trying to improve access or improve quality, the who part of it becomes just as critical as the what. And that's really the core idea, is that we can't look at it as an afterthought, that when we build solutions, it must work for the people that are most vulnerable, rather than trying to take a solution that works for the median patient and then somehow retroactively apply it. And I think what I've learned in my career is that when you do that, that approach actually works for a lot of people. When I was in Chicago and I noticed a lot of my patients couldn't make it for their appointments, but a lot of them were text messaging, we said, well, why don't we build a text messaging based system to help people with their chronic conditions? And you know what? That worked for people who did have phones and did have emails, but it also worked for those who didn't. And I think that is a core design principle that I've learned in my career.
Well, Dr. Nundy, thank you so much for sharing your perspective and some of the details on your framework and your book. I'm excited for you now to join our panel of experts and talk more about how we make it a reality.
Yeah, my pleasure. Looking forward to it.
Well, thank you, Dr. Nundy and Todd. It's a fantastic discussion, gives us so much to think about it. Drive-by office visits. I guess we got a cup of Starbucks at the same time. Well, let's continue this conversation with our panel of AMA experts who will discuss what it's going to take to get distributed, digitally enabled, and decentralized care, and how the AMA is working towards that goal. We have with us today Todd Askew, AMA Senior Vice President of Advocacy, Meg Barron, AMA Vice President of Digital Health Innovations, Dr. Karen Kamitic, AMA Group Vice President of Health Outcomes, and Dr. Aletha Maybank, AMA Chief Health Equity Officer and Senior Vice President. And of course, we still have Dr. Nundy and Todd Unger. And now, as we proceed to our panel, we have the name of this is the overall theme: what is it going to take to get distributed, digitally enabled, and decentralized care? And how is the AMA working towards that goal? Please start.
Thanks so much, Dr. Kreidel. I couldn't think of a better set of experts here with the AMA to answer that question that you posed. I'd like to welcome them and Dr. Nundy to a discussion of the paradigm that Dr. Nundy laid out and what we're doing about it here at the AMA. I'd like to start with kind of a lightning round, 2 minutes each to our panelists to talk about, from your perspective, we're about to emerge, hopefully, from this pandemic. What do you think the single greatest challenge is going to be to healthcare as we emerge? Todd, why don't you start?
Sure. Thanks, Todd. It is an exciting time, and I think we have seen, throughout the pandemic, the opportunity that telemedicine and new technologies are going to can help revolutionize care, provide better care. But I do think it is an immense challenge, given the regulatory framework that's in place. A lot of the flexibilities that we were able to take advantage of during this period will expire when the public health emergency does. And even when you have a desire among the part of policymakers to continue some of these flexibilities, there are things like the statutory requirements on geographic and site of origin restrictions on Medicare telehealth services that it's going to take an act of Congress to change that. The regulators can't do it on their own. And for those things that regulators can do, look, regulators see the benefit, but they also see fraud and they see overutilization. And they're limited in how much they can really consider the benefits as opposed to the potential downsides and the potential threats to program integrity. And then I think also the other challenge on the other side of the payment coin is the payers. The payers see a great deal of opportunity, and they see opportunity for savings. And it's not savings they're going to reinvest in the healthcare system. We're already seeing payers providing or talking about financial incentives for patients to seek virtual care in favor of actually going to see their physician. And we're seeing efforts by payers to substitute virtual providers as opposed to building real networks of providers to meet the needs of their patients. And so, and while I mentioned even before the pandemic, we were seeing your health insurance company will cover virtual care, but only through a commercial provider of telehealth services, not with your own physician. And that can really disrupt care too. So the challenges are the opportunities are clear, but the challenges to overcome both on the payer and regulator side to make it a reality and to keep focused on how it can best serve the patient is really going to take everybody working together.
Yes, it looks like you and the advocacy team at AMA have your work cut out for us.
We all do.
And never such an important time to speak with a unified voice on behalf of patients out there. Meg, you are deep into digital health. Can you talk about, what do you think the biggest challenge is?
Yeah, I would really echo a lot of what Todd just said. For me, it's really about progression versus regression. And the biggest challenge we face right now is how do we ensure that we don't allow this incredible progress that we've made for virtual care and really the trajectory that we're on for digitally enabled and distributed care overall really take massive steps backwards if concerns over payment and coverage or for originating site, as Todd mentioned, aren't further or permanently addressed. So there's so many opportunities right now, but really it's how do we leverage the progress that's been made as a springboard to continue to really ask, why have we been doing it this way for so many things in healthcare, right? And we're at this pivotal moment to move beyond implementation of just these technologies and really to optimization so we can think about right care, right time, right modality of care. So that's a blend of in-person and virtual, and really allowing the patient and physician relationship to guide those decisions. The last thing I'd say, just real quick, is digital health investment is at an all-time high, which is both an opportunity and a challenge to make sure that these investments are done equitably and that the solutions that are rolling out really keep physician workflow and all in mind for all.
Yeah, we don't want to see the progress measured in terms of megaphone and parking lot.
Yeah.
Dr. Kometic, why don't you speak toward that end, because you've been working a lot on that kind of distributed element of this equation with your work and home monitoring, blood pressure. Why don't you talk about what you see as the biggest challenge?
Thanks, Todd. As I reflect on the horrific year we've all been through and the lives lost and the struggles and the pain, what we did hear from all of that, right, are the voices. We heard the voices directly from physicians, many on this call today, and patients. We heard directly the voices of families and communities, and they told us, right, what they needed, what was lacking, what was missing. And it strikes me that in order to take that voice that we heard which have the solutions, right? All of those people have the solutions if we listen. And to try to harness that urgency and ingenuity that came from it, that our biggest challenge, honestly, I think, is to keep listening. To keep listening to the front line of physicians, care teams, the patients they serve, the communities in which we all reside, because from there we will know what to do next and what to put together. So challenge I see is to keep listening. And then opportunity with that is to pivot. And I couldn't agree more with Dr. Nundy to pivot and put this energy on reimagining chronic disease prevention in our nation. You know, still leading causes of death and disability in our nation. Imagine if we can all together focus there as we had to, as we were forced to out of necessity on the pandemic over the past year. And the thing is, you know, we don't need a new vaccine. You know, we have the tools, we have the evidence to address these leading causes of death. We need the new approaches, and those approaches are going to come from keep listening.
Thank you, Dr. Kometic. Dr. Maybank, you heard discussion in the interview with Dr. Nundy about the role of equity and innovation and about that intersection. You and the team from the Center for Health Equity just released AMA's strategic plan for health equity, and I know that innovation is a key part of that. Do you see that as the pivotal kind of challenge here as we emerge from the pandemic, or is it something else?
Well, I think, you know, I agree with Dr. Nundy and what he mentioned in terms of one of the great opportunities, and somebody else may have mentioned this as well, during this time of COVID was the exposure of inequities. And then also, you know, and it's opportunity at the cost of people and harm of people, to be clear, but also the public murder of George Floyd presented this opportunity where we've been able to explicitly and directly talk about inequities, but also to name structural racism where we weren't able to do that really in a kind of massive way across this country because of how many people really felt uncomfortable when talking about racism. And we saw all this opportunity that declared racism as a public health threat, even by us as the AMA. And I think what was, also powerful in Dr. Nundy's presentation and his framework is that, you know, what COVID did was really elevated this imperative around the need to have equity strategies that help improve the health of all people. So when you speak about, you know, distributed and decentralized approaches, those are core to equity strategies that people have been speaking about for years. And so I think it's, you know, it's brilliant to repackage and reframe it in a way that maybe it's digestible to more people, but this idea of becoming more proximate to people and where they live and where they are is absolutely critical. And so therefore, I think the greatest challenge actually in this pivot is what was mentioned a little bit by Meg, is that we don't regress, you know, so we've made this progress to talk about equities, to name them, to name, you know, racism as a public health threat. And for the entire healthcare ecosystem, I think there's a lot of internal work to do as institutions and individuals to better understand and respond to this science and evidence that we do know exists as far as the root causes of why inequities exist or why they're present. And it's going to take, I think, a certain amount of humility to kind of admit we don't know everything, but we need to be committed to find out why. And I think there we can talk later on, you know, other ways to do that. And then we have this opportunity to use our power and leadership, as Dr. Nundy mentioned, and inspire others to continue to grow and evolve to meet the moment in our commitments of, again, following the science, but ensuring optimal health for all. And I think it's optimally like staying this course to what we have pledged to say we were going to do. You know, especially us as AMA, we declared racism as a public health threat, and we committed to dismantling racist policies and practices to healthcare. So how we continue to hold our own feet to the fire, how healthcare continues to hold their own feet to the fire as it relates to racism is going to be really critical.
Thanks, Dr. Maybank. Dr. Nundy, you heard from, I think, all four panelists, this idea of not losing traction on, you know, the gains that we've made over the past year in the face of the pandemic. And you've got four leaders here at AMA that are very, very pivotal to kind of bring your vision to life. So as a practicing physician, you know, what tools and resources would be most valuable to you as you seek to deliver on this vision of distributed, digitally enabled, and decentralized care?
Yeah, absolutely. Well, first of all, just hearing the commentary from everyone, it really, it's almost a dream to have folks reflect, and particularly Dr. Maybank reflect on the framework and its utility. So thank you for that. When I think about what's most valuable to me, so I think a lot about this patient I took care of a few years ago. She was, in her 70s, in and out of the hospital with heart failure. And after one of these hospitalizations, I saw her in clinic, and, like I always did, I said, hey, remember to check your weight every day. If your weight's up a couple pounds, give me a call. And I kind of walked out of the room, and I probably woke up on the right side of the bed that day, because I went back in. I said, we keep talking to you about this weighing scale thing. Do you have a weighing scale? And she kind of, looked down at the floor and said, no, Dr. Nundy, I don't. I can't afford one. And, I ran around our clinic. We have all this fancy equipment and sophisticated software, but we didn't have a weighing scale to give her. And so I handed her $20 out of my pocket, and she was never hospitalized again. And I think about that with respect to the framework, right? So when I talk about distributed, right, I mean, clearly for this woman, who's dealing with heart failure, which is very behaviorally driven, understanding her home environment, if care started at home for her, right, whether that meant virtual, whether that meant a community health worker, whether that meant me going to her home and doing a house visit, we would have gotten to the root cause of that much, much earlier, right? What's a survey in a clinic hits you over the head when you're standing in someone's home. The second is digitally enabled, right? Like this idea that, even if she did check her weight, how hard is it to get a hold of me in that moment, right? They have to call my clinic and leave a voicemail and then tell the operator, and then I call them back. I mean, it shouldn't be that hard to relay information as critical as, hey, my weight's up a couple pounds, I need some help. And one of the things that's been really fun during the pandemic is I'm texting with all my patients now that I have a clinic phone. And then the third is this idea of decentralized, right? Which is that, look, I could have ordered her some third line expensive heart failure medication. I could have given her a cardiac cath and put her in the hospital for $10,000. But why couldn't I give her a $20 weighing scale? I think that when we talk about decentralized, we need to be putting the resources in the hands of doctors and care teams who understand what each patient needs. One patient might need a third line heart failure medicine. Hallelujah. Someone else might need a cardiac cath. But what she needed was a weighing scale. And who knows that? Is it the administrators? Is it the health plan? Who knows that? I know that because I'm here with her in the room. And so I just want to make it concrete. Like, that's what I'm talking about. And those are the kinds of changes that I think would have been transformative for her and, across the board for my patients.
Yeah, what's clear is, this is not a simple fix. It's a systemic issue that touches on a number of different areas to make the vision work. I'm going to go right into another kind of lightning round, 2 minutes each for our panelists to talk about your top priority right now in terms of the work that you're doing on behalf of physicians and patients, and what our members at the AMA can expect to see in the future. So Dr. Maybank, why don't you start it off? 2 minutes, please.
Sure thing. Thanks, Todd. Sorry about that. I think get the unmute. So for me, top of mind is our AMA Health Equity Plan, and making sure we are distributing that. But we've received overwhelmingly positive feedback from both internal amongst members, but externally from leaders all the way up to the White House COVID-19 Health Equity Task Force students. Dr. Nundy mentioned that there's nothing like a student, in the messaging that they send and the inspiration that they get from reading the things that they feel are meaningful as leaders of the future. But we've received from other academic centers and some of the largest foundations in the country, and even corporate America, such as PayPal, gave us great feedback about the plan. But we've also received some very helpful feedback that supports us knowing where there are gaps in terms of understanding, again, the evidence and the science regarding the root causes of inequities. And this just means that we need to do more work, not just share and socialize the plan and the primer as in the document, but also to really work to amplify some of our existing educational tools, such as our Prioritizing Equity series, create more educational opportunities, to really amplify the roots and, again, the science, especially through our AMA Ed Hub, to elevate the voices of physicians and students and patients who have been historically discriminated by our system that we may not hear from, whether they're identified as disabled or LGBTQ or women and people of color. I think as Karen mentioned, we need to continue to better understand and listen to those who still want to understand more about the plan. And then I think ultimately what's very critical to doing equity work as well is just really building and executing on partnerships and collaborations that will drive equity work forward in not an incremental way, but in a really true and transformative way.
Thanks, Dr. Maybank. Dr. Kometic, why don't you take 2 minutes and to review your top priority right now?
Thanks, Todd. Our top priorities remain to help physicians help their patients to prevent cardiovascular disease. And in particular, we focus on hypertension and the prevention of type 2 diabetes. I mean, we imagine a world where everyone who has hypertension is at their goal, everyone, all populations, no disparities in outcomes. And everyone who has prediabetes knows that and has an opportunity to prevent or delay the progression to type 2. And so our strategies are threefold, and we have some new things that I also want to share that we're thinking hard about. So the strategies are threefold. One, we offer to all healthcare organizations, including federally qualified health centers, population dashboards. Okay, we believe it starts with data. As Dr. Nundy said, it doesn't end there, but everyone should have access. All physicians, where and when they want it, should see their patient population with hypertension and prediabetes. And we are now offering that stratified by ethnicity, race, and gender identity. And with the guidance of the AMA's plan, we hope to add social determinants of health and equities as well. So to Dr. Nundy's point, that information is at the fingertips of physicians and care teams. We offer that at no charge to all health organizations. Second thing we do is we offer education directly for patients. And we're trying to, again, listen there as to what does a patient need to be able to say, take their blood pressure at home. So we're offering that in different venues and different voices leading that message, not just us, in partnership with groups such as the National Medical Association and the Academy of Black Cardiologists and others to help us get that messaging right and out to everyone. And the third thing is advocacy. Again, I'll use the example of taking your blood pressure at home. You know, those devices should be covered in every health plan. We're seeing it more and more in Medicaid plans, which is great. We need it covered by Medicare in every public and private plan. So that's been like the core strategies, you know, help health organizations with the data, educate patients, advocate for what's needed to remove any barriers. And then I'll just add what's new is with all humility, trying to learn from the communities.
Thanks, Dr.
COVID
Kometic.
taught us not just what is healthcare, but what happens out in the community. Thanks.
Excellent. Thank you so much, Dr. Kometic. Meg, you and the team at AMA were hard at work on telehealth prior to the pandemic, which allowed you to kind of push out an entire telehealth implementation guide right as the pandemic kicked in. Now, what do you see as the top priority for you and the team?
Yeah, overall, I mean, our top priority is how can we help to ensure technology is an asset and not a burden for physicians. So to this end, our work is centered in research and the development of really pragmatic resources to help guide physicians and the industry. So 3 quick examples of this, Todd, you mentioned, you know, we have a series actually of implementation playbooks. The first was around remote patient monitoring, and the second that we released, again, right during COVID and really drastically expedited our timeline for was for telehealth. And really, these are step-by-step resource guides that basically are based on lessons learned from practices and health systems all across the country. So think really soup to nuts, from selecting a vendor all the way to assessing your results or knowing what success looks like. The second is a telehealth immersion program that we just launched. And this is a curriculum of webinars, live interactive sessions, virtual panel discussions, on-demand resources that really deep dives into different aspects of telehealth. So now pretty much everyone has stood up telehealth or virtual care in some capacity, but there are so many nuances to still work out related to how do I scale this? How do I optimize my workflow? How do I address concerns related to technology access and other components? So this is corely focused on that. And the third is research around measuring the value of virtual care and looking at that more holistically. So how do we move beyond just short-term financial returns for virtual care, but really look at, again, more comprehensively, the value that's being created on the back end for patient access, for health equity, for patient and physician satisfaction. So we've created a framework that helps practices and health systems start to measure this in a more comprehensive manner.
Thank you so much, Meg. Todd, you mentioned up front, there's a lot of stuff that we need to continue to work on. Again, not to lose the gains that were made and the advancements is, you think about your top priorities going in this post-pandemic. What's the top one you're working on right now?
I wish we just had one, for better or worse. It seems like we have dozens, but let me mention a couple very quick, Todd. One is the financial pressures that practices are under, both from the pandemic, but also from payers, from payment quality programs, and so for some pending cuts in Medicare. If you can't keep your doors open, if you can't hire the staff, if you can't invest in the technology, it's very difficult to innovate. And so we have to make sure practices remain strong and able to engage in these activities. And the second I would mention deals with payment models under Medicare. Physicians don't see a connection between how some of these models they're required to participate in or reporting they're required to do actually translates to better care. And so we're looking at how do you reimagine this whole quality enterprise so that physicians can lead, physicians can take care of their patients in the ways they know will improve care, and that will be the basis of quality, actual improving quality, rather than just checking boxes that somebody in the bureaucracy has decided need to be checked.
Thank you so much, Todd. We're going to head into another round of a little bit deeper questions, but 2 minutes per panelist with a specific question. Meg, I'm going to ask you to start by telling us a little bit more about some of the innovative approaches that you're seeing in the marketplace right now or coming soon.
Yeah, first, related to innovative approaches, I'd be remiss if I didn't mention how really incredibly inspiring it's been to see how adaptive and innovative practices have been, and really reworking, in some cases overnight, their entire workflows to stand up virtual care to meet the needs of their patients in this pandemic. The stats we've seen, as Dr. Nundy even said, a vast majority of physicians really, were not using telehealth in any form. And then that spiked to upwards of 90% of physicians using it in some way, shape, or form. But again, this is tremendous innovation in a very short amount of time. Now we need to kind of take a breath and say, like, what's working really well? And then again, how do we focus on optimization? I'd say the other aspect that relates very much to Karen's work is from research we did this past year with the COVID-19 Coalition, which is an initiative led by MITRE and Mayo and a number of others. There's so much opportunity for remote patient monitoring right now. Despite this not being a new technology, only about 11% of physicians that we surveyed indicated they were performing remote patient monitoring with their patients in their home. And if they were, the reporting experience was nearly all manual at this point. So that in itself is just a massive opportunity to think about EHR integration, really solution integration into the workflow. We see examples of this being done really well at groups like Ochsner and Henry Ford, who are already seeing great outcomes, clinical outcomes, as well as part of, again, further integrating these solutions into practice. And then lastly, I would just quickly mention just hospital at home and health at home is, I think, at the tip of everyone's tongue at the health system and practice level. And Kaiser and Mayo just recently announced $100 million investment that they're doing in this space. And again, this has tremendous opportunity to truly meet patients where they are.
Thank you. Yeah, it's pretty exciting. We had a chance to talk with a CMO from Henry Ford on a COVID-19 update and the kind of equipment that they're equipping patients with at home. That's pretty exciting in terms of progress. Well, Dr. Kometic, let's hear your 2 minute round now. We heard a little bit from Dr. Nundy about addressing hypertension and diabetes in new and innovative ways. How do you think this model of distributed, digitally enabled, and decentralized care can improve outcomes in these areas?
Yeah, thanks, Todd. I think the framework is terrific, not only to lead us toward the outcome, but help us think about what are we missing in order to get to that outcome. So I'm just going to use briefly, again, self-measured blood pressure at home as the example in each of the 3 Ds. And Dr. Nundy, you can help me out if I'm interpreting correctly. But so when I think about it, we start with the evidence. always the evidence, the science, right? And we know that if someone can take their blood pressure at home with a validated device and do it well and relay those readings to their physician and have the discussion, it does in fact lead to lower systolic blood pressure. Check, we've got science, right? So then I think about distributed, okay? So we want this to happen at home. Dr. Nundy in his book writes so eloquently about his frustration of not having home COVID testing, right? So this should just be ubiquitous, that we all can take our blood pressure at home. So what do we need to make that distributed? You know, just a couple of things. Physicians said to us, they said, we don't know if we can trust those home readings. Are they accurate? Are those devices accurate? So the AMA has funded an independent process to determine that those devices are in fact validated for accuracy. Great. We've, as I said before, we're doing the education for patients. We're also thinking about how does that work at home financially, right? And so CMS now reimburses for physicians to interpret those home readings. So that pathway has also been greased to enable this distributed model of home blood pressure measurement. Imagine, you know, everyone, we get up, we brush our teeth, we rest for 5 minutes, we take our blood pressure, the data is sent to our doctor. The second D, digitally enabled. I think this is where we need the most work when it comes to taking your blood pressure at home. Right now, the ability to relay those readings to your physician is very vendor specific. The solutions. There are a couple that are agnostic to whatever particular device you have at home, but we need more that are completely agnostic so that everybody can avail themselves of that. And of course, it was mentioned earlier, we have a problem with the digital divide in our nation, but this is probably where we need the most work, and we've got to start with, for whom is this solution? And the last, just quickly on decentralized. So when I think about home blood pressure measurement and the decentralized leg of this stool, we are now starting to work with community health workers because, you know, if you don't use something, you lose it, right? So the physicians can teach their patients and the care teams can teach their patients how to do their blood pressure at home, but you might forget, right? You might need a refresher. So what if, you know, as an extension of that clinical practice is a community health worker saying, let me help you refresh on how to do that. So that's how I'm thinking about the 3 Ds. Dr. Nundy can help guide us if I'm right or not.
I'm going to just to ask you before we move on to Dr. Maybank, if someone wanted to find out about those validated device that you mentioned, where would they go?
Yeah, please go search on the web for vdl.org, and you will find that list of an independent process who has reviewed those devices.
Thank you so much. Dr. Maybank, health equity or lack thereof was a central theme of the pandemic, as we saw, you know, health disparities magnified for marginalized and minoritized populations. You know, what advice would you give to physicians seeking to advance health equity in their practices? Where do they start? 2 minutes, please.
Yes, thanks, Todd. I think one of the gaps that still happens and still present, and while the terms of inequities has been elevated, there's been exposure with the data, I still think there's a lack of understanding, again, of the science and the evidence behind inequities and even the definitions and the terms. And I think it's important for physicians who have not been trained in their medical school training, you know, oftentimes, or residency on these topics and the root causes, to find trusted resources to learn more about, you know, how inequities may be operating in the sense of their practice. And to really reflect that we understand, you know, it's not about intention. Majority of us have good and great intentions around how we want to deliver care and make sure that care is great for our patients. However, the evidence and science shows us that even despite those great intentions, the impact of some of our decisions at the practice level, at the institutional level, the individual level, are not necessarily meeting our intended desire to really ensure optimal health for our patients, and sometimes harming. The evidence shows us that. And so I think it's really important that we go to our trusted resources. We can go to AMA, we're building the resources. We have, again, our Prioritizing Equity series where we talk to voices across the country and leaders and people and physicians. We have our health equity resource page on the AMA website that you and your team have been very supportive in building out, and people have been going to that. Excuse me. We also have our Health Equity Resource Center on the AMA Ed Hub that is also building out with tools and modules so that folks can go and listen as well.
Mhm.
And I think, I'm just going to respond to something because I see it in the Q&A. It's important to understand that these inequities, we're stating that they're unjust, that they're avoidable, and that they're unnecessary. And they didn't just happen. They're not just natural. They're not just inevitable. The evidence shows us that they've been produced and they're sustained by the systems that exist. Whether, again, intentionally or unintentionally, they prevent people from living, their full life and full health potential. And we have to make sure and understand, that it is beyond just focusing on the individual and their behavior and their biology, but really looking at the systems that are at play in our society. And so when we do mention systems such as racism, or systems such as sexism, or systems such as ableism, these systems we know historically structure opportunity and assign value based on some characteristic, or whether it's race or gender or class, and they disadvantage people and offer advantage to other people. And we have to be able to see that and name that and understand how that can produce the inequities that we see. And I think just one other point, to what Dr. Nundy mentioned, and I think applied and Karen said as well, is that folks can speak to their patients, especially those within your practice that have the worst health outcomes, and find out what is happening in terms of their experience with your practice and their experience overall in life. That is important data that I think oftentimes is not collected and useful to really center and understand the barriers. And if we can correct and fix the barriers for those who have the worst health outcomes, that just helps everyone overall. And it's an important type of equity strategy, and it doesn't take away from anybody else's health. And I think it's a critical way also of building trustworthy institutions as well.
Thanks so much, Dr. Maybank. And I would encourage everyone out there, all viewers, if you haven't already looked at it, to download the AMA's strategic plan for health equity, and you'll get a better sense and far more background on these systems that Dr. Maybank referred to and what the AMA is working toward. Last person in our panel here, Todd, 2 minutes. I'd like to hear more about the link between regulation and innovation. With relaxed regulation during the pandemic, stimulating a lot of experimentation and innovation, what's the regulatory climate look like going forward, and how do we ensure, there's room for innovation?
Thanks, Todd. We have to recognize that a lot of these flexibilities are going to come to an end fairly soon in some cases. But there has been an acknowledgement by the administration that we've learned a lot. We've gathered a lot of data. We've tried a lot of new things, and they want to very closely examine what has been learned and how we can incorporate those things into our payment system. The early energy has been enrolling back regulations from the previous administration, and the priorities of the current administration in terms of regulation in the healthcare sphere are really just kind of becoming to the forefront with the pretty delayed confirmation process. We're just getting all the pieces in place, but there's some things that are clearly need attention. I mentioned the payment structure under Medicare and the disconnects there, but there's other areas. One I give with good intentions, the information blocking regulations. Part of that was to make sure patients can see their results and see their test results, for example, just as soon as possible. But you've left a lot of patients and physicians in pretty serious distress because they're getting some pretty confusing information directly from their labs, for example, and no way to interpret it, no opportunity. So good intentions need to be, one thing, but there's a lot of, problems in the regulatory system that means it's not as suited to addressing kind of what we're talking about in the innovation space around patient care. And so the best thing for all of us to do is we'll continue to talk to the regulators. We continue to push. We continue to talk about best practices with them. But we got to demonstrate it. We got to do it. We got to take that physician leadership and implement these programs where we can, as Dr. Nundy has referenced. And the regulators will eventually learn from our example of what is possible.
Thanks so much, Todd. Well, Dr. Nundy, you've had a chance now to hear from all of our panelists about the work that they're doing right now. We also have a lot of medical students and residents in our audience participating in these section meetings and in our House of Delegates. What should they be thinking about? And how should they be thinking as they complete their training and enter the physician force about making a difference in this paradigm? 2 minutes, please.
Oh, wow. I think you're entering medicine at just an absolutely historic moment. And I just couldn't be more excited about the next generation. I think when I was in med school, a thing I heard over and over again was, listen to the patient for they're telling you the diagnosis. And I think we heard that word listening a lot today. And I think as I reflect back on my career, there are special moments that you have that you don't get back. When you're a med student, you get to sit in a room with the patient for 30 minutes, an hour even. I used to chart in my patients' rooms and really get to know people, ask them the why questions, understand what their home environment's like, understand what their relationship with medicine and their doctors have been. Because those moments, that time that you spend, that's what you're going to build on for the rest of your career. I still, when I make decisions now, reflect on just the deep understanding. I grew up in a bubble. I think in some respects, we all grow up in bubbles. And I think really that opportunity, that privilege we have as doctors to hear about the most intimate, personal parts of our patients' lives, it's truly a treasure trove that has sort of enabled everything that I've been able to achieve. And I think that the second is that I think you should look at this. I think everyone keeps saying this once in a 100-year pandemic. This is a once in a 100-year opportunity to reinvent healthcare. If you think about, we spent the last year, every day Americans are reading about a health issue, right? Every single day we've been innovating on the front lines of care. I think the AMA probably made its most historic, move forward in its entire history through the health equity strategy that it's developed and approved. I think it's an incredible moment for a new generation of physicians to lead in a different way and really push the entire healthcare system in our country forward. So
I think you're absolutely right. I'm hearing the sense of excitement and this opportunity to make change. So final lightning round, 1 minute for each of you. What do you think is the most exciting thing or the most exciting takeaway for this audience? Dr. Kmetic, why don't you start?
I would say that to me is that we also have the attention of patients and families like never before. And to take advantage of that in the personal conversations that you have, as Dr. Nundy mentioned, and for us as staff of AMA to take advantage of that in new ways. Physicians remain the trusted voice, and it came through the pandemic. And I think I'd like to see us to continue to make that connection with patients and families at all levels.
Thank you, Dr. Maybeck.
Yes, I probably won't take a minute. I think, we're in a time where I think there's so much alignment across the country, so much openness across the country to talk about issues and root causes in ways that we have never before. And there's alignment from the policy perspective, the corporate perspective, business, health, all of it, and if we do not take advantage of this opportunity right now, these doors close. That's my experience in doing this work. I think it's the experience longitudinally across time. And I think we have this opportunity of which we can all show up as leaders from this AMA space, especially. People are looking to us and looking for us and want to work with us and partner with us as it relates to advancing equity across this country. So my hope is that we take this opportunity on with great urgency and rigor.
Thank you. Todd.
Well, I agree with what Dr. Maybank just said wholeheartedly. And I think the most exciting thing is that we've had a glimpse of kind of some of what is possible, of some of the ideas, and that people can innovate and people can find new ways to do things and provide better care. And so to me, it is an exciting time that we have identified a major problem and we've identified a major opportunity to start to make a difference in that area. So I just think that the takeaway here is that there's probably not been a more exciting time to be involved in medicine and healthcare policy.
Meg?
Yeah, I would echo everyone. And again, back to progression versus regression, that we're at this moment where it's so much harder to swallow. No, that can't be done, or this is how we've always done it. And after living through this last year, and the bar has really been raised for what can be accomplished. So I think that's really exciting.
Dr. Nundy, you wrote this book to inspire leaders across medicine with this new vision. You've got 1 minute. How would you wrap up what you're finding most exciting about this discussion?
No, honestly, I think just the fact that we're having this discussion, I think, says a lot, right? I think the AMA, all of you, all my panelists, we are meeting this moment, right? This is a catalytic moment. We haven't solved anything, right? But we have, like Dr. Maybank said, the level of alignment, the feeling of urgency, the desire to question how things are, the unacceptability of the status quo, the applauding of the frontline health workers, the leadership of the AMA. I mean, all of those things together, I think, are creating a catalytic moment. This is our moment. We don't know how long it's going to last, but we know we don't get these often. And so let's make the best of it together.
Well, thank you so much for the inspiration for this panel. First, I wanted to say thank you to our panelists, Dr. Nundy, Dr. Kometic, Dr. Maybank, Todd, Meg. It's inspiring to get to work with you every day. I thank my lucky stars, and also want to thank our physicians, residents, and students in the audience. You're the leaders that are going to help implement this vision. And it is an exciting time. We've got a window here and a lot of urgency. So with that, I will turn it back to Dr. Kreidel.
Well, thank you, Todd. Wow, that was great. And thank you to Dr. Nundy and our panel of AMA experts. So much opportunity for innovation going forward. It's been so energizing to hear about the challenges and opportunities presented by the pandemic, a great opportunity to improve, and how the AMA is working to reshape care to better and more equitably serve our patients. So now, as you head off to the important work of your individual sections, please remember that it is your policymaking efforts that drive and strengthen our American Medical Association. Your voice and engagement make the AMA uniquely qualified to serve as physicians' powerful ally in patient care. And in summary, we do this by removing obstacles that interfere with patient care, by driving the future of medicine to tackle the biggest challenges in healthcare, by leading the charge to prevent chronic disease and confront public health crises, as we've seen in the pandemic, and representing physicians with a very unified voice. And this strategic work is fueled by 3 AMA-wide outcome accelerators: advocacy, innovation, and equity, all of which you heard about from our panelists today. And I hope you enjoyed that panel. Thank you again for your commitment to our work. I hope you all have a great meeting, and I look forward to seeing what you accomplish in the coming days. Thank you so much, and goodbye.